This is the Clark County EMS PCEP in-service for the fourth quarter of 2011. This in-service will consist of three-part series. Part 1 will be this video lecture on Advanced 12 Lead. Part 2 will be strip interpretations, and Part 3 will be a brief practical. Medics in Clark County have been interpreting 12 leads now for almost 2 decades. This county has set a high bar for the rest of the region to follow. Having said that, there is always room for improvement and additional knowledge on the subject. For some of you, this will be a review, or validating what you already know. For others, this may be new information, and some of it will be motivation to push yourselves to gain more knowledge on this subject. The problem with many 12 leads are they never look like the training strips that we see in textbooks or in our ACLS courses. Rhythm generators produce very clean strips and make it less challenging for us to read. The reality, however, is they look closer to this. Artifact from movement, poor connections, and interference cause strips to be more difficult to read. Before we talk about Advanced 12 Lead, we need to view a few basics, like what leads look at. However you remember the lead views, whether it be the Lidley-Sal method or memorization of the 12 lead table itself, there should always be a way that you can quickly recall the 12 lead views and locations. If you cannot review this from your memory, you need to develop a method to do so. Because not all ST elevation is indicative of an MI, we must know those ST abnormalities that do mimic an MI. For the sake of easy recall, we have narrowed it down to the big four. They are paced rhythms, LVH, left bundle branch blocks, and pericarditis. A fifth mimicker that is less common is early repolarization, but more about that later. Paced rhythms create ST elevation when no MI is present. Here, in this strip, the pacer spikes are readily apparent, but that is not the case in all paced rhythms. Acquiring a 12 lead on a patient who is known to be paced is not necessary due to this common mimicker. In other words, if you can easily detect the pacer spikes in your 3 lead, then no information from the 12 lead strip will help you determine if this patient is a cath lab candidate, except if you look for specific criteria in waveform morphology that we will discuss later. In this strip, some leads clearly show pacer spikes, while others do not. But what is clear is the ST elevation that is obvious in leads 2, 3, and AVF. Another strip showing ST elevation with an active pacer. If you're going to pace a bradycardic patient, conduct a 12 lead prior to doing so, that is to eliminate the creation of these MI mimickers. LVH is responsible for up to 30% of the ST elevation. To determine if LVH is present or suspected, use this simple criteria. Look at the S wave in V1 and the R wave in V5, or the S wave in V2 and the R wave in V6. Some literature uses the criteria of either V1 or V2, whichever is higher, and either V5 or V6, whichever is bigger. However, RMPD wants to narrow that specific indicator down to only these married leads and not to cherry pick between whichever ones are biggest. Remember, if the amplitude gain equals or greater than 35 millimeters of elevation, you suspect left ventricular hypertrophy. Here we see an ST elevation in the septal and anterior leads, but closer evaluation reveals an ST mimicker, left ventricular hypertrophy. V2's S wave shows 20 millimeters of amplitude, while V6's R wave shows 16 millimeters of amplitude. This patient would warrant every treatment modality as a STEMI except no cath lab activation. So in short, this is a potential cardiac event, just not a STEMI. A good clinical presentation and patient history will often reveal a febrile patient complaining of a sharp or stabbing chest pain that may change with movement or inspiration. It may radiate in a classic cardiac way to the left arm and neck. Lying supine may increase the pain, while leaning forward may ease the discomfort. Associated symptoms could include dyspnea, tachypnea, or dysphagia. Cardiac friction may be heard through auscultation, although this only appears in about half of the patients. At first look, this EKG is alarming. Elevation across numerous leads may trigger you to begin treating the patient with nitrates and aspirin. But upon a closer look, the ST elevation has a concave presentation, almost like it could hold water. A more diagnostic approach is that you notice the elevation widespread across all leads, a trait that is very unlikely in a typical heart attack. Some clinicians will have an easier time recognizing PR segment depression in leads that have the ST elevation. This sign is so suggestive of early onset pericarditis that it is almost considered diagnostic. A common mimicker is a left bundle branch block. However, to keep the patient as a STEMI activation, the left bundle branch block must be a new event, not one that has been associated with this patient's condition before. How do we know? Well, we can ask the patient, or we can use the Scarboza criteria, but we'll talk more about that later. What criteria must be met to be a left bundle branch block? First, the heart rate must be supraventricular in origin. In other words, not a ventricular-driven rhythm like V-tach. Next, the QRS duration must be greater than or equal to 120 milliseconds or 0.12 seconds, which is 3 little boxes. If the criteria is met, then we look at V1 and start at the J point and move left towards the QRS complex. Does this terminal complex drop, or does it rise above the isoelectric line? If the terminal complex is down, it's a left. If the terminal complex is up above the isoelectric line, it's a right. That's basically it. Here's a supraventricular rhythm with a wide QRS duration, 0.160. So we look at V1, and the terminal deflection is up. Therefore, this would be a right bundle branch block. This is another supraventricular rhythm with a wide QRS complex. The duration here is 0.122 seconds. We look at V1, the terminal deflection is down. Therefore, this would be a left bundle branch block. Last one. We have a supraventricular rhythm with a QRS duration of 0.156 seconds. Wide in duration. We look at V1. Terminal deflection is downward. This is a left bundle branch block. When interpreting a strip, it is best to be organized in your approach and thought process. This way, simple things will not be overlooked. Almost all of these observations are accomplished quickly, especially when taking full advantage of the information that is provided to you on a typical LifePak 12 or 15 printed strip. As we know, only interpretations that are viewed in the diagnostic mode are reliable. Therefore, look to verify that the monitor is in diagnostic mode by looking at the Hertz range. ST changes are captured in the lower frequencies, below 1 Hertz. Acceptable ranges are 0.05 to 150 Hertz or 0.05 to 40 Hertz. Here, the LifePak 12 range on this monitor is set at 0.05 to 150 Hz. Next, scan quickly to see if the calibration or gain is set to 1. This is very important when looking at left ventricular hypertrophy. Next, look at the heart rate. Is it too fast or is it too slow? What is the QRS duration? Normal is less than 0.12 seconds. If it is 0.12 seconds or greater, look for a bundle branch block at lead V1. Finally, the PR interval. Normal is 0.12 to 0.2 seconds. Anything longer, look for a heart block. Put little faith in the machine-generated interpretations and trust your findings. So let's take a break for a moment from strips and put our priorities for our cardiac patients in perspective. Here are the goals of therapy for these chest pain patients. Each one of these points provides a therapy to the patient. They are ABCs. If they're not there, provide them first. Position of comfort. Theirs, not yours. 12 leads are best recorded in a supine position, but someone who is short of breath and having crushing chest pain will not tolerate this position. Remember, we're trying to provide therapy. Oxygenation. Now only if the SpO2 is less than 94% or if they are dyspneic. Pain management. This reduces anxiety, fear, and apprehension. Treat dysrhythmias and deliver to the cath lab. The first three goals of therapy are all BLS in nature. Paramedics want to get to pain management, but before they can do that, they have to apply the tools of assessment, all of which are BLS in nature, with the exception of the IV start. A 3-lead is obtained prior to a 12-lead. The 3-lead determines rate and rhythm only. Here where we would determine if the rate is too fast. If it is greater than 150 and they're unstable, we would cardiovert. If the rate is too slow, less than 60, and they're unstable, we would pace or a pharmacological intervention of atropine. Or if the rate is ineffective, such as PEA, VFib, or asystole, we would either defibrillate, do CPR, or both. Okay, let's get back to our strip interpretations. Keeping organization in mind, let's start with the confirmation of our diagnostic mode. Next, our calibration. Then, the heart rate. Is it too fast or is it too slow? If so, we would fix that now. Remember our goals of therapy. We'd be between oxygenation and pain management right now. But before we do pain management, we need to look at the QRS duration first. If it's abnormal, then any ST elevation would most likely be a mimicker. The QRS duration is normal, so we look at the inferior leads for ST elevation. Do you see any? Yes, in leads 2, 3, and AVF. So we delay nitrates and perform a V3R and a V4R to rule out a right ventricular infarct. Only one of these right-sided leads has to show ST elevation to suspect this RVI. Now we can perform nitrates if no suspicion of an RVI is present. Do you see any other ST elevation? Now we are deciding if this patient qualifies as a STEMI. Consider the other big four mimickers. Are there any? Pacer spikes, left ventricular hypertrophy. There are no amplitude issues in V1 and V5 or V2 and V6. Pericarditis. Is there widespread ST elevation? No. That would have been a STEMI patient and we would have activated the cath lab. Here's a 92-year-old female complaining of nausea. In our 3-lead assessment, we determined that the heart rate was not too fast or too slow. If so, we would have fixed it. Let's start with the confirmation that we are in diagnostic mode. Next, calibration. Remember our goals of therapy. We'd be between oxygenation and pain management. But before we do pain management, we need to look at the 12-lead a little further. Is there delay in the QRS? Yes, 0.146. But we still need to access or assess the inferior leads for ST elevation regardless. Is there any ST elevation? No. Now we can perform pain management or nitrates as long as the blood pressure allows it. Now we are deciding if this patient qualifies as a STEMI. Nope, there's no evidence of a STEMI, and if there was, we have already identified a potential mimicker, a bundle branch block. So let's look at V1. The terminal complex before the J point is an upward deflection. Therefore, this would have been a right bundle branch block and not an indicator of a mimicker.